Welcome back to this scientific session on the topic of coronary MRA and plaque imaging. My name is Yibing Xie. I'm from Cedars-Sinai Medical Center. I'm delighted to be joined by my co-moderator, Anthony Christodoulou from University of California, Los Angeles. We have 3 excellent talks lined up. It's my pleasure to introduce the first talk titled Coronary MRI in the Big Picture, Integrating MRA and Plaque Imaging into Comprehensive Cardiac Assessment, given by Professor René Bonner from Pontificia Universidad Católica de Chile. René, the floor is yours.
Good morning, everyone. Thanks for back from the break. So I'm not going to read the title, really long. So I'm going to talk about coronary imaging. And so the question is, why do we even bother about doing coronary imaging? Because now we hear all about photo counting CT, and we get fantastic images. But anyway, I just love doing it, and some other people here in the room as well. So we keep doing it. And one reason is MR is non-invasive. We all know this. We don't need contrast agents. There are known side effects, and we think the images look nice. And obviously, we can integrate it in a comprehensive cardiac MR exam and cover thereby the entire CVD disease spectrum, going from atherosclerosis to ischemia to myocardial infarction. And before I talk about new techniques, I just wanted to review, let's say, what we know about the clinical value of this technology already. So for instance, we know that high-intensity plaque imaging allows us to predict future events. For instance, if you see high-intensity plaques in a patient, the event rate can be up to, the annual event rate can be 16%. Also, if you do CMRA, also there are very nice data from basically the group in Japan, from Hajime Sakuma, who has been showing that, again, we can predict event-free survival, or if patients do not have obstructive CAD, we know these patients are going to be doing well. We can do this test on 1.5T or a 3 Tesla scanner. Again, the negative predictive value is extremely good of the technology. So basically, we can rule out a coronary artery disease. And as I said, if we do a CMRA in patients with cardiovascular disease, we also can predict the annualized event rate. So if there's no obstructive disease, it's very low, 0.6%. If they have 3-vessel disease, we know it's more on the order of 3 to 4%. And what they also could show in this study is if you add basically a CMRA to clinical risk factors, you can improve basically risk stratification of those patients. And this is a very nice study from Debbie Lee's group, who basically performed a comprehensive CMR exam, basically which matches the title of my talk. So basically they combine stress perfusion with rest perfusion, LGE and CMRA. And what they could show is that the area under the curve is improved if they were adding the information from the CMRA scan to the LGE. They showed it was improved on a patient-based and vessel-based analysis. And I think also very important is that they could show that they could reduce the false negatives from 20 to 1 in this study. And they were also adding basically CMRA to perfusion imaging, and they got very similar results. So now what can we see on a coronary scan? So if we do, let's say, a sequence where we get bright and black blood images, there we can see interplaque hemorrhage and thrombus, which are basically high-risk plaque features. Obviously, we also can image the vessel wall itself with black blood MRI. And as I said before, we can image the coronary lumen. Now, there is a problem, however, that if we want to do this conventionally, we have to run 3 sequences, 1 for the lumen, 1 for the wall, 1 for the thrombus. And this means we have to play out these 3 different sequences, and each of them takes at least 10 minutes to perform. So that's not very time efficient, obviously. And if we wanted to include this in a cardiac MR exam, probably we would be scanning 60 minutes or more. So we have to think about solutions, how this can be done more efficiently. And one way is combining the lumen, the wall, and the thrombus imaging. And again, Debbie Lee and Yibin Xi have been showing this with the catch sequence that this can be done. And then you can scan basically the plaque and the lumen in a scan between 5 and 15 minutes, depending on the spatial resolution. And obviously, you can integrate this in a cardiac MR exam. If you do it with contrast, probably takes about 45 minutes. But you also could run a non-contrast version where you look at the coronary lumen, the wall, and the thrombus, and even you can do myocardial tissue characterization in a non-contrast exam. And then obviously you still need a cine to look at cardiac function. And that could be done probably in 20 to 25 minutes. Good. So why are we not there yet? Why we're not doing this? So the problems are that, let's say, the exam requires expert personnel, and they, let's say, usually believe it's difficult to perform. Or not only believe, it is difficult to perform at the current stage without workflow improvements. The sequence is sensitive to cardiac and respiratory motion, so we have long and unpredictable scan times. This then translates into long acquisition times and much longer than that for CTA. And also, as I said, if we do sequential acquisition, this can lead to misregistration between the CMRA and the plaque scan. Now, solutions are to do simplified planning. So basically to run a whole heart sequence with either self-navigation, image navigators, or automatic trigger delay, including motion correction or motion resolved reconstruction, achieving 100% scan efficiency and thereby predictable scan times. Of course, we also have to speed up the scans with undersampled reconstruction, which allows us to either shorten the scan or push the spatial resolution. But then we could even go further and, for instance, employ super resolution for shorter scan times or higher resolution. However, here I won't talk about any deep learning in this presentation. So I'll give you some examples now about motion corrected reconstruction. And at the end, also we'll talk about the motion resolved reconstruction, basically an approach that Matthias Stuber's lab has performed in, I would say, in the last 10 years. Good, these are some slides given to me by Bob Edelman. So he's using the DNARF sequence, and then he has added in the saturation pulse that precedes a balanced SSFP readout. And using this approach, he gets very beautiful images. What I found impressive is that this can be done in 1 minute and 15 seconds. So with a Grappa acceleration factor of 9 and a reconstructed resolution of 2 by 1 by 1 millimeters. So this is a navigated scan, so really fast. That is the approach we have been proposing. So the image navigator with a spiral-like trajectory. And as you can see here, you have much less undersampling artifacts. So the reconstruction problem is much simpler. And then basically we can bin the data, estimate, let's say, motion fields, and then do a motion-corrected reconstruction to get these kind of images, either with iterative sense or basically with a post reconstruction, which is a low-rank reconstruction. Yeah, and these images have been shown already by Vanessa Ferreira today. So these are non-contrast CMRA images. On the left, you see the CT with contrast. On the right, the CMRA images without contrast. And I think the important result of that study was that we could show that the negative predictive value is very high, between 95 and 100%, depending on the coronary vessel. So we can rule out disease. And obviously, let's say we get, when you look at the cross-sectional views, you get, let's say, very similar, let's say, visualization of the coronaries as with the CT scan. And as mentioned in the talk by Daniel Giese, so workflow optimization obviously is really important. So basically, Siemens has developed an auto planning tool and an auto rest phase tool so that you basically can plan the volumes automatically and also find out the cardiac rest phase or the trigger delay automatically, which simplifies the scanning. And using this approach, a friend of mine, Yong Kim in Denmark, he achieved the resolution of 0.7 isotropic. And you can see you see different features than with the CT, but anyway, you should be able also to diagnose the disease. Now the question is, what spatial resolution is needed? At the moment, we are working at 0.9 millimeter isotropic. So Young's group in Denmark, they are pushing now to 0.7, and they could show that they could improve the sensitivity, also the negative predictive value, and the accuracy by going to the higher spatial resolution. However, of course, that takes longer. We have to keep this in mind. And we also have seen this sequence already. So basically where we combine bright blood and black blood imaging. So the first to propose this was Yibing Xi from Cedars-Sinai. So this is a very similar sequence, the boost sequence. So on the first heartbeat, we get a coronary angiogram, and then we do a subtraction of the first and the second heartbeat. And that allows us to look at the vessel wall. And this example here shows you basically we can see now basically the lumen obstruction. And we see also the reason why the lumen is obstructed. On the black blood image, we see a thrombus. But in the same scan, we also can look at the myocardium. So we see the edema that this thrombus is causing. And on the right-hand side, you see the clinical scans. And in this case, usually we run 4 scans to get, let's say, the same information. And these are some data that were given to me by Dr. Qi Yang from Beijing. They were using this boost sequence to do myocardial tissue characterization. So this is a patient with, let's say, infarction and intramyocardial hemorrhage, and you can see the iron accumulation in the first heartbeat of the boost sequence, and basically also in the second heartbeat because it has a short T1 relaxation time. But it also can be used for instance, infarction with edema. And again, in both heartbeats, you can basically now visualize the edema, which obviously is water accumulation, and T1 and T2 are sensitive to that. This slide also has been shown already. So if you compare now against CT plaque imaging, on the CT, you see extremely well the calcification, whereas on the MR scan, let's say you have higher sensitivity for soft plaques. So in basically row B, I think I can't point it here, this one, you can see basically you can visualize the plaque on this boost sequence. And the group in Denmark, they analyzed now basically those images, and this plaque to muscle ratio was increasing for non-calcified and lipid-dense plaques. However, not for the calcified plaques. So basically, we are more sensitive for high-risk plaque, and let's say we also can see plaque attenuation. Good, in the last 3 slides, I just wanted to show the approach from Matthias's group. So basically, they are having a free running sequence where they reconstruct basically respiratory and cardiac resolved images, and together with ferrum oxytol, they get, let's say, beautiful visualization of the coronary arteries, as you can see here, and in those cases. And obviously, you can push this further. And let's say there are now many approaches, basically how you can image the coronary arteries. You get everything in 3D and in movement. So I'm pretty sure the vascular surgeons love these images. Good. And since I'm over time, I think I will stop here. So I think you can read the summary. So thanks a lot for your attention. And of course, I'd like to thank my group and you for listening.
All right, thank you very much. Yes, today we have to stay quite on time because we have the dinner cruise, and it's very hard to join late unless you're a strong swimmer. So it's my pleasure to now introduce Debbie Ali from Cedars-Sinai Medical Center to talk to us about metabolic MRI of the heart. See some very exciting things that are going on.
Well, thank you, Anthony. So when I look at the program, so Judith asked me to give a talk on this session. I look at Renee's going to give a talk on overview of the coronary MRA and plaque imaging. I said nothing to talk about. I nothing to add. So I asked to change the topic a little bit. It's related to coronary imaging, but it's I think it's a new frontier for cardiac imaging. So I want to share with you some really preliminary experience with metabolic imaging of the heart. Is again related to coronary imaging, but not directly. So I thank Judith to allow me to do this change in the last minute. So I have two major topics for this metabolic imaging area. The first one is on ECG, on creatine chest imaging in the heart, and the second is on the oxygen extraction and consumption imaging in the heart. So the first topic is chest imaging to look at creatine metabolism. And this is the work mostly done by my grad student, Karandeep Chima, and a lot of other collaborators listed here. This is on using multitasking free breathing non-ECG-gated technique for chest imaging in the heart. And this is not a new topic, and there's a lot of work in the past on MRS for metabolic imaging of the heart, particularly in the Johns Hopkins group. They've done this many years. There's some well-known problems with MRS in the heart, including the low sensitivity and motion. And chest imaging had the potential to address those issues because if you look at the water proton signal can be more sensitive and more higher ISNR, and also can be spatially resolving this with spatial information. So we made a first attempt on this, and many others have done this as well in the past, including Dr. Jay Zheng. He's here from WashU in St. Louis. Chest imaging, as you all know, is very challenging. I mean, it requires a long scan time because it requires many outside frequency imaging. So we made some technical improvement to make this happen. First, why creatine imaging? So creatine is essential for the ATP generation. When at the resting condition, creatine is mostly stored by phosphocreatine. And then when the muscle or myocardium need the energy, so it will this phosphocreatine will lend the phosphate to ADP to form ATP. So then basically is really essential. Creatine is essential for the generation of ATP, and which is the main source of myocardial contraction. When there's, I think the belief is that when there's a structural disease in the heart happens before that, there usually some kind of abnormality in the myocardial metabolism. This typically happens when there's diabetes, there's hypertension, and obesity, and ischemia. They all impact the metabolism first before they cause structural or functional dysfunction in the heart. So that's why it's very important to look at the metabolism, and there's the potential for use this information to monitor disease progression and treatment response. So that's why we want to look into this and come up with the ways for MRI to non-invasively measure metabolism. And this also can be a biomarker for therapy, for exercise, drug treatment, all kinds of things we can do to improve energetics of the heart. So chest imaging is very challenging. As I mentioned, there are many offset frequencies. In this case, we do 55 offset frequencies in order to calculate this chest signal. So the time is very long, and in the heart, even longer. I mean, there's some earlier work who used the segmented acquisition can take up to 1 hour to do, or more than 1 hour to do cardiac chest imaging. So this is the work we did a few years ago, and we used this single shot flash readout in the cardiac cycle to prepare with the CEST B1 irradiation at different frequencies. The total preparation plus the acquisition time is up to 500 milliseconds, which is very long in the heart. So, but this is a way to reduce scan time. But despite this challenge, we still get some pretty good images, and And also this work by the Beijing Union Hospital, they use this technique to look at the patients with amyloid light chain amyloidosis. They come up with some interesting findings that this SAS signal could have a very good correlation with the LGE scar assessment with this type of patients. Still, there's still an issue. There's a lot of long acquisition window in the cardiac cycle is causing a lot of problems, the blurring, motion artifacts. And so now we're adding this SAS dimension to this multitasking technique that we've been doing in the heart for many years. And this is just another dimension that we want to add, allow us to resolve the SAS signal from different offset frequencies. So with that, we could reduce the preparation time of this B1 power and also reduce the acquisition window for each module. So we collect about the total, including the preparation and acquisition time, is about 70 milliseconds. So this is pretty much acceptable for the cardiac imaging. And we have tested this in the brain and in the liver, and showed pretty good results in the last few years. And now we're moving that to the heart, and with both cardiac and the respiratory motion resolved, the imaging with the multitasking. Here's some more details of the acquisition, and it's again 55 frequency offsets, and we do 3 slices with a total time of 8 minutes. There's different bins, and the offset frequency for creatine is 1.8 ppm. Here's some raw images that shows the different time resolved imaging slices with the retrovirus bin with the different slices and different offset frequency. It just shows the quality of images, which is not perfect, but it's sufficient for some studies shown here, human volunteers. It's supposed to be a complete uniform map of the creatine, but obviously it's not. So there's some slight variation. So we did a little bit calculation of that. I'll show them the numbers here. But we also did some plaque imaging. This is the chronic MI PIC study at 3T, and we compared with the LGE scan here. You can see some infraction and show the obvious signal change here in the SAS map. So there's a pretty good correlation here. And some numbers, we look at the homogeneity of the SAS signal across different segments of the heart in human volunteers. And we find pretty, uniform distribution. There are some changes, but it's not statistically significant between the different segments. But in the PICs, we look at the remote myocardium and the myocardial infarction. We did see a significant change in the creatine SAS signal. Interestingly, we look at also a group of volunteers with different BMI. There's a well-known study showing that obesity induces the marked impairments of the mitochondrial function and loss of ATP. And so we see that, it's not perfect. Again, there are a lot of scatter, but you do see a trend of a reduced creatine level in the more obese patients or BMI increases. So it's the same thing with phosphocreatine. So you do see both trend of going down when the BMI increases. So we did some initial study, look at the effect of dobutamine, which Vanessa talked about this earlier. What is the impact of dobutamine and dipyridamole for the heart function, the heart pressure? I think when you have dobutamine, you increase the heart rate, the pressure product, so you need more oxygen, need more energy to have the normal function. So you can see when you have this the dobutamine injection to the PIC heart, you do see a big change in the creatine level, and so, because you need more energy in the ATP, in the form of ATP. So that's what we've shown here. Again, this is not the conclusion. This is just some evidence that that shows that we do see similar trend as people have shown in the past, but we do not have enough cases yet to make a conclusion. So we also did another study to use, and this is just some examples of the images, and we look at there's some the lateral level is there's some signal heterogeneity. So we use the septal area to measure the signal between the before and after dobutamine, and you see a big change in the SAT signal. We did the same thing with adenosine, which only vasodilates the coronary without raising the cardiac work. So we do see that the both creatine and phosphocreatine level remains more or less the same. There's not much change, which is again verifying the same finding people have done in the MRIs. Here, another example of that, the image, and you show that in the septal area, we measure the signal change. They're all more or less pretty much similar. So in conclusion, that we have tested this free breathing non-ECG gated assess imaging based on the multitasking framework and I3T, and show some interesting results, but this is not the end, of course. There are a lot of further improvement are needed, and in particular, the motion detection is a challenge with assess imaging because you have this saturation pulse really saturate a lot of the blood, a lot of the water signal in certain frequencies that make the motion detection or training data very low SNR and a little bit challenging to detect motion from that. The other is that the scan time is still pretty long, about 8 minutes for 3 slices. So we're testing this undersampling frequency domain and using AI to recover the whole spectrum, and which we have shown that in the brain published this year. So we want to do that in the same in the heart. Still, there are more work need to be done to optimize the P1 power and also include T1 mapping to improve quantification. Of course, in the end, we want to validate with MRIs and also explore further clinical applications. In the interest of time, I would stop here, and I just mentioned that there's actual work that by Randy Young in our group who is doing this oxygen efficiency assessment with myocardial imaging and show some interesting results. And this is really look at the Bode effect and T2 measurement of the coronary sinus to calculate the myocardial, let's see here, efficiency, basically the mechanical work divided by the total oxygen consumption, and really shows very promising results. Again, this is based on this multitasking framework to measure the flow, to measure the T2, and calculate all those. And he tested on a number of patients and animals and look at the validation using invasive measurements of the O2 set, and also look at the infraction peak with the heart failure with the preserved the ejection fraction, and look at how because of the heart failure, the heart is not very efficient, so you need more oxygen to do the same work. And he shows that clearly in this animal model. Another is that when you have stenosis in the aorta, you have obstruction of the blood flow, so you need more work. There's a lot of increase in the afterwork of the heart, so you need more pressure to do the same functions. You need more oxygen. So it showed that as well. This is in real patients, and show in this aortic stenotic patient, you do have increased oxygen extraction compared to the control population. Again, this is still ongoing, and this is still early, and he's looking at the different type of patients and how to use this information to really solve some important clinical questions. So I'll stop here and acknowledge the whole team at Cedars and collaborations with UCLA and Johns Hopkins and all the grant support. Thank you.
Thank you, Debiao. Again, in the interest of time, we'll have to skip the Q&A session, but I encourage everyone to connect with the speakers if you have questions during lunch. So we'll move on to the last talk in this section, and which is going to be given by Dr. Alison Hayes from Johns Hopkins University, with the talk titled MRI of Endothelial Dysfunction, a Window into Early Vascular Disease.
Thank you so much. Good morning, everyone. It's an honor to be here today, and thank you for the session organizers. So I'm going to provide some background about some of our earlier work, but then kind of go more into what we've been doing with our non-contrast coronary MRI stress techniques. So before starting, it's important to recognize the regulatory function of the vascular endothelium, which is a cell lining layer that lines every single vessel in our body. And really the role is to maintain vasomotor tone and vascular integrity. So vessel permeability, it regulates things like inflammation, thrombolysis. In the setting of cardiac risk factors or known heart disease, there's definitely an imbalance towards vasoconstriction, thrombosis, and increased adhesion molecules, which can create an environment of pro-inflammatory effects on the vascular endothelium, and then can create an environment that makes it more favorable for plaque formation and plaque progression as well. The reason this is important in the coronaries is because most MIs are predicated by less than 50% stenosis. And one of the interesting things about endothelial function is it really precedes the development of luminal stenosis. So it occurs much earlier on and can predispose to plaque vulnerability. Now, the way we can measure it easily in humans is by giving someone an endothelial-dependent stressor, and that's really defined by nitric oxide-mediated stressor responses. So one can either use cold pressor testing, isometric hand grip exercise, which initiates shear stress, and then causes the endothelium to release nitric oxide, which then leads to a signaling cascade that incites cyclic GMP and vascular smooth muscle relaxation. In the cath lab, typically acetylcholine is used intracoronary for the same results. So just to review, the normal endothelial response in response to any of these types of stressors is to have an increase in coronary artery area, flow, and velocity. However, an abnormal response is either have no change in coronary area, flow, and velocity, or actually vasoconstrictor response. And that makes the coronary arteries very unique, as opposed to the systemic vessels, which never vasoconstrict. So we've used these techniques, which we'll get into, to really answer some interesting questions, to look at traditional and identifying novel cardiovascular risk factors, to look at subclinical disease progression for earlier diagnosis. And then more recently, we've taken it to clinical trials and looking at mechanisms of disease. And so this test really allows you to look at nitric oxide-mediated disease versus endothelial-independent disease, which is not mediated by nitric oxide. And some of our original rationale for using these techniques is that typically for over 20 years, people have used brachial ultrasound to look at peripheral endothelial function. However, the physiology of both vascular beds, the brachial versus the coronary, are quite different. And peripheral arteries, such as the internal mammary or the brachials, are not prone to plaque rupture. However, the coronaries are. So they're quite different in terms of their physiology. So in our initial studies, these sequences were developed by Matthias Stuber together with Bob Weiss at Johns Hopkins. And we use non-contrast techniques with spiral cine MRI, alternating breath holds for area as well as flow velocity using phase contrast techniques. In addition to looking at endothelial function, we also do comprehensive cardiac structure and function assessment, as well as T1 and T1 row mapping, and then a modified body composition protocol, because we're very interested in that as well. In terms of our stress protocol, we identify coronary arteries at baseline during 6 to 8 minutes of continuous isometric hand grip stress at 30% of maximum. And then we often also include recovery as well. In terms of results of our initial paper, was quite a few years ago at this point. This shows coronary artery at rest and during stress in a healthy individual, and no change in coronary area size with isometric hand grip stress in someone with CAD. We also look at changes in coronary velocity down the coronary. So you can see an increase in intensity of pixels in a healthy person, showing an increase in velocity and flow down the coronary artery, and no change in someone with coronary artery disease. In our initial paper, we validated and showed that people who are healthy, shown here in blue, have an increase in coronary area in response to isometric hand grip stress. And then there is an incremental decrease in a vasoconstrictor response in those who had severe CAD compared to mild. And as controls, we also administered nitroglycerin, which is an endothelial independent stressor. And it shows that even though there is an abnormal vasoconstrictor response of the coronaries, they were still able to all vasodilate, showing that the coronaries were intact and not too calcified. So our initial studies really use this technique using 3T MRI, non-contrast coronary MR, to look at coronary vasoreactivity for the first time in humans. However, some of the criticisms earlier on was, is this really looking at nitric oxide mediated response? This had been validated using the brachials years ago, but we decided to perform an experiment to further validate the technique. So we administered an inhibitor of endothelial nitric oxide synthase called LN-MMA, and it's an IV infusion. And we want to test the contribution of endothelial NO to the coronary response. So in this experiment, we performed coronary MR at baseline. We had isometric hand grip exercise number 1 without anything, just like we usually do. And then we started to administer the blocker of nitric oxide synthase called LN-MMA, and then repeated the hand grip. We used this as an inhibitor to test to see if the response disappeared on healthy individuals who have high levels of nitric oxide. And our main findings for this project showed that with the administration of LN-MMA, it completely obliterated the response of the coronaries in terms of our 3 metrics: percent coronary area, percent coronary flow velocity, and blood flow in response to stress. We also did a control group just to make sure it wasn't a memory function, and the control group was negative. So one of the next steps for us as our research group was to determine reproducibility. So we had already determined reproducibility for inter and inter-observer, but we also wanted to prove reproducibility over time. So we had patients come back 8 weeks apart, and we looked at percent CSA, coronary stress area, in response to hand grip, and showed it was reproducible over an intermediate term of 8 weeks. We additionally looked at the internal mammary artery as a systemic vessel. And basically our rationale is that the IMA is frequently used as a bypass vessel. It rarely develops atherosclerosis, and it's one of the highest nitric oxide producers in the body. So in the balance of endothelial vasoregulation, there's definitely a tendency towards vasodilation. It's very healthy. So this is an example of an internal mammary artery. And the reason we chose it is because it runs very parallel to the RCA. You can see a cross section here in red at the top. And basically, it's different from the coronaries because it does not vasoconstrict, but it fails to vasodilate. So we were able to look at both vessels simultaneously and compare their response to one another. And here, this shows that basically looking at coronary versus systemic endothelial function, that there was a relationship between the two, but it was very modest. So you can have abnormal coronary function, but very normal systemic function here. So it shows that they're basically complementary to one another and not the same, which is what we expected. More recently, working closely with Mike Shar and Bob Weiss, we wanted to look at what kind of spatial resolution that coronary endothelial function studies can detect, which is important for designing clinical trials. And using a phantom developed by Jerome Yerli and Gabri Bonanno from Matthias Stuber's group, we found that we were able to detect a 4 to 5% area change from study to study with a spatial resolution. More recently, we've had new refinements which have focused on really improving the temporal resolution for the flow scans to reduce blurring. Mike Shar is looking at measuring area changes along the vessels more recently. So to summarize our earlier studies, we showed that this 3T MRI technique without contrast is feasible, it's reproducible in the intermediate term, and has provided some biological insights in terms of the systemic versus coronary vessels. So really our current studies are mostly focused on using coronary endothelial function for a clinical research tool to identify potential novel unidentified risk factors. And we've looked into different types of patient populations. We've looked at women's cardiovascular health, HIV primarily, and looked at a number of interventions, and I'll just highlight a few. A lot of our research in the last 8 years or so has been focused on HIV. There's a huge population in Baltimore, and it's a disease that's marked by a pro-inflammatory state, despite complete treatment with antiretroviral therapy. Patients tend to have still persistent chronic inflammation marked by increased C-reactive protein or IL-6. And they often accumulate metabolically active visceral fat, which then communicates with the underlying endothelial cells. So we're very interested in body fat distribution and how that impacts vascular function. So we looked at cine images of epicardial adipose tissue, EAT. We first showed that percent CSA, which is our measure of endothelial function, was reduced in patients with HIV, even without CAD, and it was worse if they had known CAD. And we also found the same thing using coronary flow. And then when we compared epicardial adipose tissue to percent CSA, there was a very strong inverse relationship. So the more metabolically active fat surrounding the coronary, the worse the endothelial function. We were also interested in other visceral stores, so we simultaneously looked at liver fat, visceral fat, and other stores. And basically what we found was that coronary endothelial function was more closely related to subcutaneous, which was very surprising to us. But there are other translational studies showing that subcutaneous tissue in HIV is much more metabolically active than in patients without HIV. So we also showed that it was related to CD4 count, but not related at all to the type of antiretroviral therapy that they were receiving. So to summarize, we found in our studies that coronary endothelial dysfunction is present at a very early age in people with HIV, even in the absence of calcified atherosclerosis. A lot of the coronary endothelial function that we were seeing was directly related to epicardial adipose tissue, as well as subcutaneous adipose tissue. And we thought that further studies may be needed to assess whether interventions targeting the metabolically active fat can improve vascular health in HIV. So that led us to look mostly at anti-inflammatory treatments, and I'll kind of skip through just in the interest of time. But we conducted a few clinical trials. One of them was focused on PCSK9 inhibitors, which modify LDL. The other one is focused on use of colchicine versus placebo. And I'll just cut to the chase here. So we conducted 3 different clinical trials. The first 2 showed no improvement with anti-inflammatory treatment using methotrexate, colchicine, or the combination, so it's very potent. In HIV, we also showed no improvement with colchicine, so it was a negative study. But we did find a very positive improvement using PCSK9 inhibition, which basically affects LDL receptors and reduces inflammation at the same time. So in summary, what have we learned about impaired endothelial function in HIV? It's impaired at a very early age and doesn't further deteriorate with age. We found that it's very closely related to epicardial adipose tissue, and it's very modifiable with PCSK9 inhibitors in particular. Unfortunately, colchicine didn't work very well to modify vascular function in HIV, and it might have had to do with the high levels of inflammation. Potentially, they might need more aggressive anti-inflammatories. These are future studies we're currently working on. And I want to acknowledge our research group, including Matthias Stuber and others. Thank you.
All right, let's thank our speakers for those excellent talks, and we will now move to the second half of this session. So I invite Matthias and Ruud to come moderate the scientific portion.
Hello, everyone. Welcome to the second part of this session. We'll start with 4 oral presentations and then 7 power pitches. The first of this will be given by Joa-Yuan Hu. Please go ahead.
Under 4 main sections: the background, objectives, materials and methods, and the results. ICAS is highly prevalent in Asian populations. ICAS patients experience more severe strokes, longer hospital stays, and higher recurrent risks, while conventional imaging method can access ICAS. High-resolution vessel wall imaging offers unique advantages by non-invasively identifying high-risk plaques and providing more accurate stroke risk assessment. Current research has shown that some plaque characteristics correlate significantly with recurrent events. Additionally, some clinical factors are proven risk factors for stroke recurrence. However, few studies have comprehensively combined clinical risk factors with intracranial plaque imaging features to predict stroke recurrence. Therefore, our study aimed to, number one, explore clinical and the plaque characteristics associated with one-year vascular event recurrence in acute ischemic cerebrovascular disease patients. And number two, develop and validate a nomogram for predicting one-year vascular event risk. Here are our inclusion and exclusion criteria. We prospectively enrolled acute cerebrovascular disease patients from Beijing Hospital. Baseline information was collected with follow-ups every 3 months. Patients with symptom progression or new symptoms underwent immediate vessel wall imaging. Asymptomatic patients were rescanned at 1 year. Imaging was performed using 3D TOF MRA, pre and post T1 space sequences. Plaque characteristics were manually evaluated using the Vessel Explorer software. Here are the statistical methods we employed. We recruited 129 patients. During a media 12-month follow-up, 29 endpoint events occurred. Patients were randomly divided 3-to-1 into training and validation sets. We compared the baseline plaque and clinical characteristics between the training and validation sets and found no statistically significant differences. Multivariate Cox regression identified 3 independent risk factors: the maximum plaque length, coronary artery disease, and NIS score greater than 4 were independent risk factors. A nomogram incorporating these factors plus intraplaque hemorrhage, sex, age, and diabetes was developed. The AOC for the training set was 0.807 with a C-index 0.826. For the validation set, the AOC was 0.916 and the C-index was 0.74. Collaboration curves demonstrated good agreement between predicted and accurate probabilities in both sets. At the threshold probability of approximate 5 to 95%, the model provides more net benefit in the training set than strategies of treating all or none. At the threshold probability of 10 to 55%, the model offers great net benefit in the validation set than these alternative strategies. Based on X-style analysis, the cutoff value for high-risk and low-risk groups were 110.6. The high-risk group had a risk of one-year vascular event recurrence about 6.201 times higher than the low-risk group. This is an MR imaging case of an enrolled patient, a 65-year-old male without diabetes or coronary heart disease, presenting with a NIS score of 8 and the acute infarction in the right MCA territory. As we can see in the picture, the MRA revealed the mild stenosis in the M1 segment of the right MCA. The maximum plaque length was 5.42 mils. The nomogram yielded a total score of 116 points, categorizing him as high risk. Indeed, 4 months later, the patient experienced recurrent stroke in the same MCA territory. Our study identified plaque length, coronary heart disease, and NIS score greater than 4 as independent risk factors for one-year vascular events. The developed nomograms show good discrimination and can effectively predict recurrent risk of ischemic cerebrovascular disease patients. Thank you for your attention. I welcome your questions.
Thank you very much. Questions from the audience? Yes?
Thanks so much. That was a great talk. So if you did your nomogram, but you removed intraplaque hemorrhage because that wasn't independently associated, and you just used the risk factors that you have and the plaque length, that's all very easily obtainable without an MRI, what were your findings in that case? I guess, did intraplaque hemorrhage make a difference in terms of your predicting acute stroke by adding that?
Yes, thank you for your question. We analyzed the whole patient group, like 129 patients, and we found the intraplaque hemorrhage was another independent risk factors, but it's not an independent factors just in the training set. So we add it into the model, and we see the model perform better.
Thank you. I have a good question myself as well. Does this generalize now, is this now deployable elsewhere, or is it only usable in your own hospital yet because of the training set? Or could other centers also use now this model as you developed it? Because you trained it only on your own data?
Just training in our own data.
Okay, so have to do a multi-center to use it elsewhere?
Yes, yes, thank you.
Thank you. Thank you. Let's move on then to the next speaker, who is Qinshin Wang from Tsinghua University.
Hello, everyone. My name is Qinshin Wang, and the topic of my show today is spatial feature extraction of calcification from MRI and its correlation with fibrous cap rupture of carotid plaque. So first, I'm going to introduce the background of this research. Globally, stroke remained the third leading cause of death and disability. And rupture of carotid vulnerable plaque is one of the primary causes of ischemic stroke. Carotid vulnerable plaque refers to an atherosclerotic carotid plaque that carries a high risk of rupture, and its main pathological features include LRNC, IPH, FCR, inflammation, and neovascularization. So for stroke prevention and control, early identification of carotid vulnerable plaques are of great significance. And now the non-invasive imaging, including CT, MRI, and ultrasound, suggest several factors that influence fibrous cap rupture, including IPH and large LRNC. But current studies lack research on correlation between calcification and FCR risk. Although large LRNC and IPH are high-risk features in atherosclerotic plaques, FCR does not necessarily occur, and a considerable proportion of plaques with intact FCs also exhibit these high-risk factors. So we suppose that potential unknown factors may further influence fibrous cap stability. In molecular biology and ex vivo histopathological studies, it's already found out that small calcifications can act as local stress concentrators and further increase the risk of fibrous cap rupture. Also in hemodynamics research, which indicates that high wall shear stress can lead to plaque rupture, small calcified regions are found out to increase the wall shear stress, further trigger the plaque rupture. So the objectives of this research is first to develop a pipeline for extracting spatial features of intraplaque calcification from MR, and secondly, to determine the relationship of spatial features of intraplaque calcification and FCR risk. For methods and materials of this research, first of all is the study population. We included 147 patients with moderate to severe carotid artery stenosis. 57 cases of them developed FCR. For the imaging protocol part, we used United Imaging 3T scanner equipped with an 8-channel carotid artery coil. Here are the 4 MR sequences we used for the imaging part. So here's the image analysis of this research. We extracted two types of features of the intraplaque calcification. First of all is the morphological features. We used surface volume ratio and normalized calcification area as 2 indexes. For the spatial distribution features part, we used 2 different distances. One of them is the distance from calcification to lumen, and the other is the distance from calcification to IPH. So first of all, we want to discover in hemorrhagic plaques, what's the relationship between the morphological features of calcification with FCR risk. We integrated 3 models with different covariates, and we did this multivariable logistic regression analysis. We found out that surface volume ratio as a morphological index had significant association with FCR in all models. Secondly, we want to find out that what's the spatial distribution of morphologically high-risk calcification has to do with the FCR risk. First of all, we want to screen for the so-called morphologically high-risk calcification. Here I use the standard of surface to volume ratio larger than 0.75, because we already found out that surface to volume ratio has a significant relationship with the FCR risk. So next we want to analyze the spatial distribution of those high-risk calcification. We used the 2 distances. The Hoteling's T2 squared test results showed that the p-value is less than 0.05, which means that the spatial distribution of the morphologically high-risk calcification has indeed significantly associated with FCR risk. So furthermore, we want to find the specific sites that of the high-risk calcification that may represent high-risk factors for FCR. So we identified spatial locations of the FCR group and intact FC group. So the high risk in the FCR group, the high risk calcification exhibit a clustered distribution here. So we propose that the high risk calcification at this specific sites may represent high risk factors for FCR. So here are my conclusions. High-risk intraplaque calcifications associated with FCR are characterized by, sorry, here's a mistake, higher surface volume ratio and within vulnerability zones. So future studies will expand sample size, further validate spatial accuracy through CT and pathology, and integrate hemodynamic models to unveil mechanisms. So here's the acknowledgement of this research. Thank you for your attention.
Thank you very much. Any questions? I have kind of the same question I had before also. How generalizable do you think this is? Because these clusters, as they were in your diagram, they are relatively low numbers and so on. So if you have another 150 patients, do you think you will observe the same distribution?
Yeah, exactly that's what I want to do in the next part of this research. I want to expand my sample size, and I want to find out what's the under, if it's, true for other samples. Yeah.
Thank you.
Uh-huh.
There's no further questions, then thank you very much. We move on to the next speaker, who is Simon Littlewood from King's College.
Okay, thank you very much for the introduction. So we know that cardiovascular disease is a major worldwide problem. And for coronary imaging, as we heard a lot about yesterday, the gold standard for non-invasive imaging is a CT coronary angiogram. However, there are, of course, inherent problems with CT, such as the use of ionizing radiation and contrast media. And it also struggles somewhat in very heavily calcified disease. So MRI offers a potential alternative, and also has the advantages of being able to integrate a complete exam with functional imaging and tissue characterization. However, when we look at this map, we can see that access to MRI is a major problem worldwide, particularly in large parts of Africa and Asia and some parts of South America. Professor Stuber very elegantly outlined or put the case forward for low-field CMR. And I think low-field CMR is really exciting for its potential to address some of the issues around accessibility to MRI in more resource-poor areas, in particular due to its significantly lower purchasing costs and running costs, and also its smaller physical footprint. It uses significantly less helium, making it more environmentally friendly. And I think also very importantly, there is the availability of a wider bore size of 80 centimeters on the current commercially available systems. And this makes it far more accessible for bariatric patients and claustrophobic patients. And we've been able to scan patients who've never been able to get inside a conventional strength scanner before. The main disadvantages are the reduced signal to noise and ratio and gradient performance, which leads to lower spatial and temporal resolution, and therefore longer acquisition times in an attempt to mitigate this problem. So we wanted to adapt our frameworks from 1.5 and 3 Tesla to assess coronary MR angiography at low field in patients with suspected cardiovascular disease. So the framework, which may be familiar to many of you, is a ECG-triggered 3D whole heart free breathing sequence, which is contrast-free, with a BSSFP readout. K-space is sampled using a variable density spiral-like Cartesian trajectory with 3 times undersampling. The blood pool contrast is generated with a T2 preparation pulse with 4 refocusing pulses, and a fat saturation pulse with a flip angle of 180 degrees is used to improve coronary depiction. And image navigators are incorporated into the sequence to allow for 100% respiratory scan efficiency and predictable scan times. Other important parameters are detailed in the blue box at the bottom. And image acquisition was performed in diastole, where patients' heart rates were below 70 beats per minute, and in systole otherwise, and also in cases of significant arrhythmia. So we recruited and successfully scanned 27 patients with a range of different cardiovascular conditions, with all participants completing the scan protocol. The mean age was around 61 years, and the average scan time was around 7.25 minutes. We divided up the coronaries into a 9-segment model and assessed each segment for image quality on a 5-point Likert scale, where 5 represented excellent image quality and clear depiction of the vessel, and 1 represented an uninterpretable or vessel not seen. And where available, we compared the images to CT coronary angiography or invasive angiography. So here's the image quality scores for the individual vessel segments displayed in the table and in the stacked box plot on the right-hand side. And as you can see, when we look at the graph on the left-hand side, we can see that there's pretty good image quality for the proximal segments. However, when we're looking at the distal segments, on the whole, it's pretty disappointing. So unfortunately, the movie isn't playing for the whole scan, but you can see the reformats here on a patient with normal coronary arteries. So you can see the reformat of the right coronary artery and left main stem into the LAD on the left. And this is showing really quite nice coronary depiction of the proximal and mid segments in this patient. Here's a second patient, again with normal coronary arteries, but this time with a CTCA for comparison. And again, when you compare the reformats of the right coronary artery in the top panels for the CMRA on the left and the CTCA on the right, you can see really good comparison between the two. And again, with the left main into LAD on the bottom. So this is all well and good. We can see some normal vessels, but can we see some pathology? So yeah, here's a patient with an anomalous right coronary artery arising from the left coronary cusp, as depicted with the blue arrows. And you can see on the MPR on the middle panel how the origin is pinched between the aorta and the pulmonary artery. And this is, again, demonstrated on the comparator CTCA on the right-hand side. So here's a patient with coronary artery disease in the right coronary artery. And the white arrow here demonstrates the areas of luminal stenosis, which are depicted in the patient's proximal right coronary artery. And finally, here's a patient with coronary disease in the proximal LAD with the different views. And I think this is displayed really nicely on the MPR on the far right-hand side. You can see clearly the luminal narrowing here. So in conclusion, we've been able to demonstrate the feasibility of CMRA at low field with a predictable scan time of around 7.25 minutes. The proximal and mid segments were reliably well seen. However, it was pretty limited for the distal segments. And this is likely due to the reduced lumen size in the distal segments, some signal loss, and possibly some residual motion artifact as well. We demonstrated the potential for detecting anomalous origins, as well as potentially some ability to detect coronary artery disease. But this study was limited by a relatively small sample size and low number of patients with comparator imaging. I'd like to thank my colleagues at KCL. Thank you.
Thank you very much. We have time for one quick question, if there is one. Yeah, Giles?
Five excellent as to what you perceive a coronary MRA should look like, or was 5 excellent pegged to your comparator gold standard of a CT?
No, so I think you're right. It's excellent given what I think it should look like on CMRA. So is the vessel clearly depicted? Little to no artifact? Can we see clearly the origin and the course of the vessel? That's how I considered an excellent result. Good being, we could see it quite clearly, but maybe there was a little artifact there. And then 3 being adequate. 2 noisy, not very clearly seen at all, and then one obviously uninterpretable. So it was for the CMRA rather than as a direct comparison.
Thank you very much. And
Thank
we'll
you.
have to move on to the next speaker. So who is Xiaoyi Chen from Tsinghua?
Okay, thank you for your introduction. The topic today I want to present is risk factors for coexisting extracranial carotid and intracranial artery high-risk atherosclerotic plaques and MR imaging. I will introduce my research from the following 4 parts. As we all know, stroke has become the second leading cause of death worldwide and imposed a significant burden on global health because of the high morbidity, high mortality, and disability rate. There are many diseases that can lead to stroke, including the atherosclerosis, myomelia, dissection, and so on. Atherosclerosis is a systematic disease that usually affects multiple vascular beds. Increasing evidence shows that coexisting atherosclerotic plaques had high risk of ischemic stroke. In addition, it has proved that patients with high-risk atherosclerotic plaques had high risk of developing future events. The features of high-risk atherosclerotic plaques, which will be referred to as HRPs in the following text, include the IPH, FCR, LRNC, and moderate to severe luminal stenosis. The clinical risk factors for coexisting plaque have been extensively studied. However, the risk factors of coexisting HRPs are still poorly understood. In the present study, we sought to investigate the risk factors for coexisting extracranial carotid and intracranial artery HRPs using the MR visual imaging. The flowchart. This is the flowchart of the study population. Patients with coexisting extracranial carotid and intracranial plaques were recruited, and the eligible patients were divided into 3 groups: the non-HRPs group, single HRP group, and the coexisting HRPs group. The conventional clinical information was collected. All patients underwent carotid MR visual imaging and intracranial artery MRA, and this table shows the imaging parameters. The plaque burden and the components were analyzed, including the wall thickness, wall area, lumen area, IPH, calcification, and so on. The association between risk factors and the 3 groups were analyzed using the multivariate logistic regression analysis. This figure shows the prevalence of high-risk plaques. The red area represents the incidence of coexisting HRPs among the 119 recruited patients. 18.4% were in the coexisting HRPs group. The patient with acute stroke has the risk factors of diabetes and family history of cardiovascular disease. This image indicates the plaque with the IPH in the left SCA and moderate stenosis in the MC. The table 1 shows the results of the univariate logistic regression analysis, and we can find there are some significant indicators. After adjusting the confounding factors, we can find that patients in coexisting HRPs group were more likely to have higher prevalence of diabetes and a family history of cardiovascular disease. There are some limitations in our study, including the small sample size, lack of the information available of intracranial artery, and other intracranial arteries were not evaluated in our study. And this is a cross-sectional study. In summary, coexisting extracranial carotid and intracranial artery HRPs are common seen in symptomatic atherosclerotic patients. And diabetes and family history of cardiovascular disease are independent risk factors for coexisting HRPs. I would like to acknowledge to the collaborations. That's all I want to share with you. Thank you for your attention. Welcome any criticism and correction.
Thank you very much. Any questions? Yes.
In the part of results, I noticed the multivariate logist regression analysis. I noticed there is a significant predictor, HDL. The patient in the co-instant HRPs showed more likely to have higher HDL level. As is well known, HDL is a protective indicator. But for the patient with atherosclerosis, so could you please explain the results?
Thank you for your question. It is exactly an unexpected result. I think the patient's complaints, the patient's complaints of the starting use is uncontrollable and unstable. The level of the level of HDL may be irregular, and I think the result may not be make sense. And on the other hand, the HDL is a protective indicators. When the atherosclerosis occurs, the level of HDL may increase.
Thank you.
Thank you very much. Any other questions? Not, we move on to the PowerPoint. Thank you again.
Thank you.
Okay, thank you very much. So the first power pitch is Bai-Ben Sun from the University of Washington. Right, looks like there has been a change.
Yeah, so I am not Bebe Sun. I just want to clarify that. I'm Mahmoud Mosabash. I'm presenting on her behalf. We're going to be talking about some findings in terms of a study that we did where we were looking at atherosclerotic plaque in brain tumor patients. So as we know, brain tumor patients have a high risk of stroke, a relatively high risk of stroke when compared to other malignancies. And, there are a number of etiologies for that, including thrombogenic processes. But in addition, atherosclerotic disease is associated with brain tumors, especially when we consider some of the treatments, including radiation and chemo, whereas there's a high prevalence of athero and other vascular beds and some evidence of it occurring in intracranial beds, but that hasn't really been thoroughly investigated. So we wanted to look at the association of atherosclerotic disease in these brain tumor patients longitudinally as well as at baseline, and to see whether we could tease out some of the factors and features in these lesions. So as part of our routine brain tumor protocol, we perform a brain view sequence at slightly lower resolution at 0.9 millimeters, but isotropic, but in order to really capture this assessment. We looked at plaque presence, plaque numbers, plaque location, enhancement, as well as the degree of luminal stenosis. We started off with a cohort of 1,000 patients that we looked at. We excluded patients younger than 18, as well as a cohort of this that we haven't completed yet, and those that had limited image quality or limited clinical data, and we ended up with 350 patients that we included for this evaluation. In terms of the data, the average age of patients was 52 years old. In addition, there was a spattering of vascular risk factors, which we're still combing through right now. But for the most part, vascular risk factors were not very high. In terms of malignancies, the highest category in terms of malignancy was grade 4, or the highest grade tumor, and a majority of our patients did get radiation and chemotherapy or immunotherapy. So in terms of looking at our patients at baseline, 36% of patients had intracranial atherosclerosis, and that increased as we followed these patients longitudinally. In addition, a quarter of patients had multiple plaques, and that also increased as we progressed through the study, and plaque enhancement generally did not increase within this cohort. We had a small group of patients over this 3.5-year follow-up that did have stroke events, 18. A majority of those did have intracranial atherosclerosis at 12, and 7 of them had atherosclerosis in the same vascular territory. And just to show you an example, this is a patient at baseline who had 1 atherosclerotic plaque involving the left V4, but subsequently developed atherosclerotic plaques involving the right supraclinoid ICA here, as well as the right M1 MCA here. So in summary, there is a high prevalence of atherosclerosis in these brain tumor patients, and there is some increase in this descriptive analysis over time. In addition, we still have to look a little further in terms of evaluating how important a factor this is in cancer patients and how it affects their survival and potential risk of morbidity. Thank you so much.
Thank you very much. In the interest of time, we move on to the next presentation, which is going to be given by Huyo Qiao from the Capital Medical University.
Hi everyone, I'm Qingxin Wang and I'm speaking for Qiao Huiyu. So the topic of this research is characterizing dynamic changes of carotid morphology in patients with carotid atherosclerosis by black blood MR cine imaging. It has been shown that the rupture of carotid vulnerable plaque with subsequent thrombosis is one of the major causes of ischemic stroke. However, plaques with vulnerable compositional characteristics do not necessarily lead to ischemic cerebrovascular events, as the dynamic behavior of arterial wall during vessel pulsing may also play important roles in plaque disruption, suggesting the necessity of comprehensive assessment of plaque compositions, arterial morphology, and its dynamic behavior. So MR cine imaging facilitates the acquisition of time-resolved images at the same vascular location across the cardiac cycle, thereby enabling characterization of vascular dynamic behaviors. Black blood cine imaging enables simultaneous visualization and measurement of the dynamic changes of both luminal and wall, facilitating detailed analysis of wall displacement and plaque composition through advanced post-processing techniques. For the purpose, this study aims to characterize the dynamic behaviors of carotid lumen and vessel wall using BB's black blood cine MR imaging and investigate their associations with histologically validated vulnerable plaque features and clinical symptoms, providing the new insights into characterizing carotid plaque vulnerability. So for the results, 80 MR black blood cine slices from 29 subjects were successfully matched with histological sections. Basic information was shown as follows. Slices with IPH or LRNC exhibited lower normalized wall indexes changes. Maximum wall thickness changes were higher in LM slices, but reduced in calcification slices. Max WT changes were protective against fibrous cap rupture. Symptomatic arteries showed lower max WT, WA, and NWI changes, but higher LA changes. Combining dynamic changes of NWI and LA yielded the highest AUC of 0.946 for discriminating symptomatic from asymptomatic arteries. So these are the black blood cine images and histological sections. The data of upper row and lower row are from the left carotid artery in a 52 male subject and the right carotid artery in a 62 female subject, respectively. The slices were histologically identified as having IPH and CA and having in A part of the figures and having LRNC and LM in the B part of the figures. So the results, the averaged waveforms of dynamic variations of LA, WA, NWI, and max WT for each cardiac phase in symptomatic and asymptomatic carotid arteries. So for the conclusions, the dynamic changes assessed by MR black blood cine imaging are associated with plaque components, fibrous cap rupture, and symptomatic status, suggesting their potential as quantitative markers of plaque vulnerability. Thank you for your attention.
Thank you. The next speaker is Shuwan Yu from Tsinghua University in China.
Hello everyone, I'm Shuwan Yu from Tsinghua University. My topic is association between the amount of carotid perivascular adipose tissue measured by MRI and carotid atherosclerotic plaque vulnerability. It has been shown that inflammation of PVT is associated with atherosclerotic disease. MR imaging has the potential in assessing the inflammation of PVT due to its extent soft tissue contrast. However, there lacks the evidence for the association between carotid PVT measured by MRI and vulnerable plaques. Therefore, this study aimed to explore the association between carotid PVT amounts and vulnerable plaque characteristics using MR visual imaging. In this study, a total of 153 patients with moderate to severe atherosclerotic stenosis were included. All patients underwent bilateral carotid MR visual imaging, including TOF MRA, T1 weighted, T2 weighted, and SNAP sequences. The MR visual images were reviewed by two experienced radiologists, and the plaque components were identified. In addition, presence of intraplaque hemorrhage, fibrous cap rupture, and A large lipid-rich necrotic core with an area ratio of more than 40% to the vessel wall were considered as vulnerable plaque components. Carotid plaque was segmented on the SNP reference images. The amount of PVT on the MR images with plaque components were quantified, including mass PVT area index, volume index. The logistic regression analysis results show that all plaque amount measurements were significantly associated with intraplaque hemorrhage and fibrous scalp rupture. After adjustment of clinical risk factors, significant associations remained between maximum PVT area index and intraplaque hemorrhage, as well as between the maximum PVT area index, volume index, and fibrous scalp rupture. In conclusion, our study suggests that the amount of carotid PVT measured by MRI is independently associated with vulnerable plaque characteristics, suggesting its potential as a biomarker for plaque vulnerability. In the future, quantitative FET imaging techniques can be used for better determining the inflammatory changes of PVT. That's all for research. Thank you for your attention.
Next speaker is Powei Liu, also from Tsinghua University in China.
Sorry, I'm not Powei Liu. So I don't know why this abstract was included in this session, because it is a myocardium work. And we have a group in Tsinghua University doing a lot of quantitative myocardium imaging. So this work is about the free breathing rapid T1 mapping for dynamic response quantification of contrast enhanced whole heart myocardium. I have nothing to declare. And as we all know, late gadolinium enhancement can discriminate the infarct myocardium, but we also concerned about the procedure of the how contrast get into the myocardium. So, for example, for the early enhancement of the myocardium, we can see the area at risk. The area at risk is much larger than the infarct myocardium. So we are trying to figure out what is perfusion procedure for the gadolinium getting to the myocardium. Traditionally, the early gadolinium enhancement imaging is a T1 weighted image, but for myocardial imaging, actually, because of the difference variation of the heartbeat, so we cannot get a very constant T1 weighted image. So we need to T1 mapping. We need to get T1 mapping to get more precise results. So the aim of the study is to develop the free breathing dynamic approach for rapid T1 mapping. The name is DART sequence for the quantification of the dynamic response of contrast enhanced whole heart myocardium. So actually, this is a new sequence design. It mainly composed of two parts. The first part is the rapid enhancement phase, and the second part is steady state phase. In the rapid enhancement phase, we have the saturation recovery sequence for 9 slices. The sequence, the image was get in the position of the when we do the when the depth frame is more stable. And after that, we do the steady state phase after the contrast enhancement, after the contrast injects into the patients for a while. And for the steady state, in the steady state phase, we can calculate the T1 mapping and also calculate the M0. And then we can calculate the dynamic T1 fitting using the M0 from the steady state fitting. And then we can get the quantitative value of T1 at the different time point. So this is mainly, this is the image we can get for the quantitative T1 mapping. You can see this is the health control. You and we play again. We can find, we can get the T1 mapping at different time point when inject the contrast. And for the patients here, we can find the contrast in the infarction part of the heart. The recovery curve is much different from the healthy tissue and also the blood pool. So in conclusion, the DART enables robust quantitative T1 measurements across the whole heart. Myocardium during impaired dynamic contrast enhanced phase is about 10 minutes. In the future, we will do the optimizing the protocol and data acquisition as well as the interpretation of the finding, and more patients should be recruited to characterize the dynamic response pattern of various cardiac pathology. So I'd like to thank our partners working on these projects. Thank you very much.
Thank you very much. The next speaker is Ahmed Safwat from the University of Washington.
Today, I'm going to talk about exploring the link of atrial fibrillation and atherosclerotic intraplaque hemorrhage in the setting of acute stroke. We first ask ourselves, is there really a coexistence between IPH and atrial fibrillation? So basically, we evaluated 439 acute stroke patients with the MRI vessel imaging protocol. IPH identified in both carotid and intracranial arteries. IPH is identified as hyperintensity compared to reference region, which is 1.5 times the signal intensity of a muscle, usually sternomastoid muscle. We documented stroke risk factors, atrial fibrillation, age, sex, race, BMI, smoking, hypertension, dyslipidemia, and diabetes. We also conducted univariable and multivariable regression analysis. In the first analysis, we found that 17.5% of patients with IPH, they had no atrial fibrillation, while almost 30% of cases with IPH, they had atrial fibrillation. Further, in the first analysis, we found a strong correlation with atrial fibrillation, but only in univariable regression analysis, along with age and male sex, which had univariable and multivariable regression analysis significance. We didn't stop there. We did another analysis with IPH-dependent variable, and we excluded patients on anticoagulants and antiplatelets at time of admission. We found a significant correlation with the presence of AFib on univariable and multivariable regression analysis, along with patient age and male sex. I think we answered the question based on our data that atrial fibrillation and intraplaque hemorrhage, they coexist together. Though what is the link between them, it's still a future direction. We are still investigating this. Take-home messages, atrial fibrillation is associated with presence of intraplaque hemorrhage on vessel wall imaging in acute stroke patients. Potential stroke etiologies may go undetected without performing vessel wall imaging. I would like to thank my team at Seattle Vascular Imaging Lab, University of Washington, especially my supervisor, Dr. Musa Basha. Thank you very much.
Thank you very much. The next speaker is Trisha Roy from Houston Methodist.
All right, thank you so much. So I'm a 50-50 vascular surgeon scientist. My clinical practice is devoted to PAD patients, and we still have devastatingly high amputation and death rates. Our toolbox for treating this is pretty limited. We have endovascular treatment with ballooning or stenting, or we have open bypass surgery. We actually don't know who's better suited for which option, and so most of us are going to choose endovascular treatment because it's minimally invasive. The problem with that is that we fail a lot. 1 in 5 of these are going to fail immediately on your table. And because of that, and with growing evidence from landmark trials, we're really getting pushed to do bypass first in many of our patients, or almost all of them, if they have adequate vein. So that's really a one-size-fits-all approach to a problem like PAD, where it's a very, very heterogeneous lesion set, where a vast majority of these would be amenable to endovascular treatment, but we don't know which ones. And when we do fail with endovascular treatment, it's mostly because we can't cross the lesion with a guide wire, and if you can't cross it, then you can't treat it. So our goal is to develop MRI methods to identify those lesions. This is an NIH R01 funded study. And we image patients with a 3 Tesla MRI prior to their intervention using KISS MRA, and then we further characterize the plaque with ultra-short echo time imaging, and we look at different procedural outcomes. So this is one where we had 21 patients, 37 lesions, and half were identified as hard and soft with MRI. With the soft lesions, we had 0 crossing failures. So these are definitely going to be amenable to your endovascular intervention versus the 40% immediate technical failure rate with the MRIs. And what's really interesting about that is often those types of lesions are invisible on our current imaging. So dense collagen and soft thrombus look the same on an angio and on CT, but with our MRI technique, we're able to differentiate that and show you that this is dense collagen and this is going to be at high risk of failure. So this is an example of an invisible lesion, which is now visible, and this was an unsuccessful intervention that led to amputation. And of course, crossing is only one part of the failure. You know, reintervention is a real problem in restenosis. And now, for the first time, we really have a way of evaluating the vessel wall response to intervention in real time, and we can see arteries that heal or fail over time because this is no contrast, no radiation, so we can safely serially examine patients. So we're really wanting to take out the guesswork and go from that to a MRI-guided precise mode of care so that we choose the right patients and the right treatments the first time, every time. Thank you.
Thank you very much. And the last speaker in this session is Mark Matusz from the Heart and Vascular Center here at Semmelweis.
Welcome everyone. My name is Mark Matusz from Semmelweis University, and I'm going to be talking about the preoperative white matter lesions on the Fazekas scale, predict postoperative ischemia, the role of MRI in risk stratification for carotid endarterectomy. So perioperative stroke remains a significant risk in carotid endarterectomy patients, and we need better risk assessment protocols. So we investigated the MRI graded for hyperinsensitives using the Fazekas grade, whether they can predict intraoperative oxygen desaturation and newly developed ischemic lesions on postoperative diffusion-weighted imaging. And we used a prospective cohort study, included patients that had pre- and postoperative MRIs, intraoperative saturation monitoring by near-infrared spectroscopy. We included a total of 75 patients with the MRIs, intraoperative NIRS monitoring with a mean age of 69.6 years. And we used the Fazekas scale, grouped them into 0, 1 to 2, and 3 for white matter hyperintensities. We used the near-infrared spectroscopy to monitor the intraoperative oxygen saturation. And postoperative MRI evaluation was used as well, and DWI was performed to detect the new ischemic lesions. So we found that 19 out of the 75 patients scored 0 on the Fazekas scale, 52 scored between 1 to 2, and 4 scored 3. So we found that the higher ipsilateral Fazekas scores correlated with new ipsilateral ischemic lesions, and Fazekas score and the contralateral oxygen saturation drop were weakly correlated, but statistically not significant. So the more severe the preoperative white matter lesions are, there is a higher risk for more new ischemic lesions. And we need to identify high-risk carotid endarterectomy patients for perioperative strokes. For that, we can use the Fazekas scale in preoperative planning. And however, we need larger studies and better refining risk assessment tools. For your attention.
Thank you very much. And this concludes this session. Please be back in time at 2 o'clock so that we can continue time efficiently so that everybody makes it to the boat in the evening. Thank you.